This is PANRE Review. We'll be going over the gastrointestinal system. My goal with this is to be short, simple, succinct, and relevant. So with that, let's get going. The first thing they have is constipation. So constipation is relevant because it is a chief complaint. It's something that patients will come in complaining of. In fact, it is the most common gastrointestinal complaint. About 15% of the population has chronic constipation. Why would that be the case? What are some of the risk factors? Take a second and think of what those risk factors could be for chronic constipation. Diabetes mellitus. Why would that cause constipation? Because diabetes mellitus affects the nervous system, and it will actually cause gastroparesis. One of them is a drug that is commonly prescribed, and that is opiates. Some of it can be just dietary. The poor American diet may be a little bit more prone to causing constipation. And with that, we would also say the lifestyle, such as a sedentary lifestyle. There is something called Hirschsprung's, there is hypothyroidism, and hypercalcemia. These are things that will cause constipation. Rome 3 criteria will evaluate sense of obstruction, sense of incomplete defecation, lumpy hard stools, straining, fewer than 3 bowel movements per week. So those are some of how you know. So if you were to ask what constipation is and when that becomes a problem, something that you need to treat and need to make an effort to. Basically, when you need to treat this, fewer than 3 bowel movements per week. Also, if they're starting to have some sort of pain. Signs and symptoms include abdominal bloating, abdominal pain, again, lumpy hard stools, straining, fewer than 3 bowel movements per week. What are your red flags? So whenever we get a chief complaint and a patient presents, your brain should be thinking, what are the worst case scenarios? So what are the worst case scenarios that could be behind constipation? Now, if you were to do your exam and you did auscultation of the abdomen, if you heard absent bowel sounds, that would be a concern. What is it that causes absent bowel sounds? I'll let you answer that because we'll come to that later. Inability to pass gas would be indicative of a major obstruction. If the individual also had vomiting, in the sense that they are now so backed up that they are vomiting. Absent bowel sounds, abdominal pain, if it is severe, absolutely severe, out of proportion to what should be going on the physical exam. But again, if the abdominal pain is just severe, then we're going to need to increase our workup and probably do imaging, including X-ray and CT scan. Depending on what the X-ray shows, usually may start with an X-ray and then beef it up to a CT scan depending on the other factors in the patient history. Rectal bleeding is also a concern. Rectal bleeding because of things such as colon cancer. Colon cancer can have that bleeding. There's lots of things that can cause obstruction. You could have some sort of cancerous growth there that's causing an obstruction. Polyps could be influential in this as well. So most of these can be diagnosed through some sort of imaging. A CT scan would be very helpful in getting a definitive diagnosis on what the source of the constipation is. However, most people come in without severe abdominal pain, just coming in with that complaint that they haven't been able to have a bowel movement, they're straining a lot, and they may feel very bloated. They still have a pretty regular, normal abdominal exam. It's not very tender to palpation anywhere. You can hear bowel sounds just fine. And so the treatment you're going to give them, depending on the severity of it all, you may just give them fiber could be something that's useful for chronic constipation, making sure that they're hydrated, even some dietary treatments if they were looking for something natural, something that's very natural that can help treat constipation would be prunes. There are also bulk There are bulk-producing laxatives. What is an example of a bulk-producing laxative? That would be Metamucil. And then there are saline laxatives, and that would be something like milk of magnesia. A lot of the times, if this is really severe and we know that it is due to fecal matter, then what we will do is we can do a enema, some sort of water enema. That's something you can do in clinic. That's something you can do in an emergency room setting. I remember doing in my emergency room rotation, I think they must have done 5 or 6 of those enemas to clear out constipation. X-ray is something that's very helpful to see. What the cause of the obstruction is. Workup can be extensive if failed therapy for 3 to 6 months, meaning, if they have chronic constipation that was mild that you were trying to treat and it just wasn't getting better, then again, you might want to do a CT scan, a colon transit study, or a colonoscopy. CBC, CMP, TSH, and X-ray. You could also do a fecal occult blood test as well in part of that workup. The workup in most cases of constipation, because for the most part there's not going to be very many big red flags, emergent causes, unless they're having that severe abdominal pain. If it's that constipation without the abdominal pain, then most of the time it's something that you can give it a bit of time and just do things sequentially. Start with some basic blood work, basic imaging, and then depending on how things go, if there are failed therapies, then you can get more advanced imaging, because the CT scans can be quite diagnostic. One of the things that's often the cause of constipation, it's something that I run into, and that would be irritable bowel syndrome. Irritable bowel syndrome is basically, we would say that it's a somatization of psychic stress that gets converted into problems in the GI system. That is something that we'll be touching on later. Small bowel obstruction. What is a small bowel obstruction? Obstruction of the small bowel, 65 to 75% of them are caused by what? So what causes a small bowel obstruction most of the time? A small bowel obstruction is most often caused by adhesions. Other risk factors for a small bowel obstruction would be Crohn's disease, malignancy, volvulus. And what is a volvulus? Volvulus is a twisting or kinking of the colon. What are the major concerns that you could have that are related to a small bowel obstruction? The major concerns are perforation, which could lead to ischemia. Signs and symptoms of a small bowel obstruction would be abdominal pain. Generally, it's crampy and intermittent. Constipation, nausea and vomiting is in 60 to 80%. So when we were just looking at constipation, which is too broad of a idea, it's hard to cover everything that could cause constipation, because small bowel obstruction can cause that, but nausea and vomiting is going to make you think that there could be a small bowel obstruction. Absence of flatulence, 80 to 90% of the time. That is one of those red flag things. If you were to listen and auscultate in the abdomen and you're delete that last part regarding auscultation of the abdomen. If the patient was to say that they have not been able to pass gas, that's something that you're going to be thinking of, that there is a small bowel obstruction. A lot of the times, because there is this obstruction, as a result of that, they are severely distended in their abdomen. They may even get to the point where they're having fever, tachycardia. Usually, if they're at the point where they are having fever and tachycardia, it means that ischemia is setting in. And they may start to develop as well peritoneal signs. Peritoneal signs are things that you would see with an appendicitis. The Rosving sign, that wave when you're pushing on the abdomen and you let go really quickly, that will cause an increased pain. There's also things like the obturator sign and the psoas sign. So those are things that may be indication of a severe small bowel obstruction as well. Diagnosis, X-ray. So the CT is more accurate, it always is more accurate, but the X-ray would show air fluid levels. If you see air fluid levels on an X-ray, you need to be able to associate that quickly with a small bowel obstruction. What is the treatment? the treatment of a small bowel obstruction tends to be surgical. So if you were to see air fluid levels, this patient has the absence of flatulence and the severe pain, the nausea and vomiting, and the constipation, this is a person that's going to be headed into surgery. If they are in a general practice and they're presenting, they're going to the emergency room. If you're working in the emergency room, these people are going to be hospitalized and prepared for surgery. But it does depend on the cause sometimes. Sometimes depending on the cause, surgery may not actually be the thing, but that's all that was listed on eMedicine. Large bowel obstruction. Large bowel obstruction. What is the symptom that you want to associate with a large bowel obstruction? Well, just obstruction in general. A sign that there is obstruction in the patient's history is what? Now, we actually went over this under small bowel obstruction, so it should be fresh in your head. No gas, no flatus. If there is no gas, no flatus, this individual needs we said an x-ray when it came to the small bowel obstruction, but I guess the best way to think about it is if the individual says they have not been able to pass gas, then emergent, get a CT scan. Risk: 60% of large bowel obstructions come from what? Malignancy. 20% come from diverticula. 5% from volvulus, which is that twisting and kinking in the bowel. Signs and symptoms: constipation. So this is a severe constipation, meaning nothing is coming out. Distended abdomen, no flatus, abdominal pain. Again, it's something that will usually be cramping. They usually will have some sort of a hyperresonant abdomen because of, think about how bloated they are. No bowel sounds. If you are not hearing bowel sounds, then that could be a sign of an obstruction. What is the treatment for a large bowel obstruction? Well, you do want to remember that these patients do need the general things such as stabilized IV fluids, but for the most part, surgery. So anytime you have a patient saying they are not able to pass gas, or if you're doing a physical examination and there are no bowel sounds, emergency should go red flag emergency. This person needs a CT scan, and another thing that is looked, these are things that they put on a test, but on an x-ray, the x-ray can help, just like air fluid levels would be indicative of a small bowel obstruction. An x-ray may show what that could be indicative of a large bowel obstruction. An x-ray would show free air under the diaphragm if there was a perforated bowel. So, sorry, that was due to my flashcard that I was associating that with large bowel obstruction. That was a little bit of a trick. So free air under the diaphragm is indicative of what? It is indicative that there is a perforated bowel, and that is not a good sign. Again, signs of an emergency. Toxic megacolon. Toxic megacolon, acute inflammation of the colon with toxicity, dilation of the colon. Dilation of the colon greater than 6 centimeters plus signs of toxicity. You can measure that dilation by using what? You can use an x-ray. On the x-ray, generally it will be the transverse colon, and the measurement will be greater than 6 centimeters. Generally, how would this patient present? This is just like in the previous two with the obstruction. The patient is presenting with abdominal pain. Remember, if they have abdominal pain and they're not able to pass gas, then you should be thinking of an obstruction. In terms of toxic megacolon, they are toxic. Usually there is a high fever greater than 101.5. They may have rectal bleeding, tenesmus. If they have a perforation, then they should be showing some peritoneal signs, which would be rebound tenderness, rigidity. Again, think about things like the heel jar test. We'll get to all of those when we're talking about appendicitis, but a lot of those would be symptoms of appendicitis. And if that's going on, this patient's going to be going into the emergency room. You're going to be getting advanced imagery, and these are likely people that are going to be going to surgery. Treatment. So what is the treatment of a toxic megacolon? So your diagnosis comes when they have abdominal pain plus a fever that's usually high. And as a result of this, you get an x-ray and you're able to see that this individual has a very expanded megacolon, greater than 6 centimeters. So that's something that you're going to be looking at. The treatment is IV fluids, making sure that you're stabilizing them. You'll consult with the GI specialist. Surgery may be required. What was mentioned on e-medicine is possibly infliximab and anti-tumor necrosis factor alpha antibodies have been shown to be helpful. What was mentioned on a different flashcard that I had done years ago is when it was talking about the treatment, decompress with nasogastric, bowel rest, IV fluids, IV steroids, antibiotics, colectomy if not resolved. So those are some other things to think about to associate with toxic megacolon. So what you're looking at in terms of relevance behind this is, what do you do when a patient presents with abdominal pain? And how are you going to work that up? What's in your differential? Because small bowel obstruction, large bowel obstruction, toxic megacolon are things that are going to pop in your mind. There are some things that will be helpful, such as an x-ray, because the x-ray can show those air fluid levels that would be indicative of a small bowel obstruction. If you saw free air under the diaphragm with an x-ray, you'd be indicative of a perforation. If the patient is not having any flatus, so that's a significant thing in a patient's history. If they are passing gas and there is some flow, then you know that they don't have an obstruction and you can move on to the next set of things. If the individual has this toxic megacolon, remember that they are looking ill. Generally, the toxic megacolon is going to look very similar to an appendicitis. This person has a fever with some significant abdominal pain. Again, they may have some of those peritoneal signs. So something that you want to think about, even when you have somebody with just a general gastroenteritis, usually you're not having that significant of abdominal pain. There also is something like you're going to have to rule out some of the food poisoning, because food poisoning can cause a pretty significant abdominal pain as well. So if you are truly worried about just the severity of pain and you're thinking, oh, this could be just food poisoning, perhaps you want to do an x-ray just to rule out something like toxic megacolon, which could look kind of similar to food poisoning, because gastroenteritis usually doesn't have that significant amount of pain. They're having much more just diarrhea, constipation, whereas you may not be having the diarrhea, constipation, you're just going to present with that abdominal pain. So that's something to maybe think about in a clinical sense. Fecal impaction. A fecal impaction is an obstructive disorder that can obviously be related to constipation. It is specifically a large hard mass that gets stuck so badly in your colon that you can't push it out. There are some cases where you do have, it's basically 98% blocked, but you can get some overflow diarrhea. The name of the overflow diarrhea is encoparesis. The risk factor for a fecal impaction would be chronic constipation, opioid use, and gastroparesis. You can do an x-ray, and what would you see on an x-ray? On the x-ray, you're going to see a tremendous amount of fecal matter building up in the sigmoid colon, going up in the ascending colon, and in the transverse colon, maybe down in the descending colon. You're going to see all of this crap on the x-ray. And what is the treatment? Generally at that point, you may, unless you have to do a manual disimpaction, you'll probably do something like an enema, suppository. There are magnesium citrate osmotic laxatives, but generally, once patients present with that significant amount of constipation, you're going to want to make sure that you've done something to treat and make it better before you just let them out the door. So again, the x-ray will be indicative of that if the patient has significant constipation. Again, what would be presenting is the patient presents and says, I haven't had a bowel movement in many days and I have significant abdominal pain. get an x-ray. What is telescoping of the bowel? What is telescoping of the bowel? The name for telescoping of the bowel is intussusception. A telescoping of the bowel is when a segment of the intestine invaginates into the adjoining lumen. Why is this a problem? Because it causes an obstruction. If an intussusception, this telescoping of the bowel, is not treated, it can be fatal within 2 to 5 days. What would be the signs and symptoms of an intussusception? Vomiting, blood per rectum, abdominal pain. Usually it's intermittent colicky pain. Remember, these individuals have an obstruction, at least a significant amount of it. So blood in the rectum is a really, really big sign. In fact, the big buzzword associated with intussusception is what? The great buzzword associated with intussusception is current jelly stools. Because remember, there is blood per rectum, current jelly stools. If that is the case, then this individual, you want to be thinking that they do have an intussusception. X-ray may be helpful, but ultrasound can be diagnostic. I would also believe that I wouldn't be surprised if a CT scan is also diagnostic. Physical exam, they may have a mass in the abdomen on palpation. But some of these are obviously going to be more of a vague and non-specific symptomatic, because obviously nausea, vomiting, constipation, and intermittent colicky pain are not enough to just make you think it's intussusception. The vomiting and blood per rectum, the blood per rectum really is the biggest red flag to say intussusception. In kids, there can be bilious vomiting. Again, there is that abdominal mass, lethargy, bloody mucousy stools. What I just saw on eMedicine is it said this: to confirm the diagnosis of intussusception, ultrasound or other abdominal imaging such as an X-ray or CT scan may reveal the intestinal obstruction. You may see what is known as a bullseye, which represents the intestine coiled within the intestine. According to Medscape, the gold standard, the traditional and most reliable way to make the diagnosis of intussusception in children is to obtain, and this is really significant, a contrast enema, either a barium or air enema. A contrast enema is quick and reliable. And if I recall, that can sometimes even be the treatment of it, because the treatment of intussusception is what? A barium or air or water enema. And if it's unable to reduce by one of those means, then this individual is going to need some sort of surgery. So current jelly stools, you have to remember that and its correlation with intussusception. Moving on, we get to infectious diarrhea. This was, to me, the most annoying of all the things that the PANRE asked me to do because they put it at a level 2 instead of a level 3 or a level 4, and infectious diarrhea is way too expansive because what are the causes of infectious diarrhea? Well, let me just sprint through like 20 of them. Clostridium, rotavirus, norovirus, E. coli, Shigella, Salmonella, gastroenteritis. So, that wasn't 20, but there's a lot of different causes, and it's a little bit unfair to just list all of those at once. So we're going to be going through these like they are buzzwords. So we're going to be going through these, focusing more so on buzzwords. If an individual had had many antibiotics recently in their history, you may be considering which form of infectious diarrhea. Clostridium difficile. If an individual had recently been on a cruise ship, the cruise ship form of infectious diarrhea would be norovirus. If an individual had blood, significant amount of blood in their diarrhea, you may be thinking of a more significant bacterial cause. There are multiple things that can cause blood in the diarrhea. That can be E. coli, Salmonella, and I can't remember if Shigella or Campylobacter will also do that. Salmonella is generally contracted from chicken. E. coli is going to be contracted by raw meat, beef, cow. Campylobacter is related to Guillain-Barré. What are the signs and symptoms of infectious diarrhea? Loose stools. Often there is abdominal pain. Campylobacter is often bloody. E. coli is often bloody. The absolute diagnosis is going to be made through a stool culture. However, the most common cause of infectious diarrhea is going to be gastroenteritis, which does not require antibiotics. That is not necessarily a bacterial form of diarrhea, whereas these other ones that were listed, most of them, E. coli, Shigella, Salmonella, Campylobacter, and Clostridium, are all different bacterial. So there is also one. What is the diarrhea known as traveler's diarrhea? That is Vibrio cholera. Cholera is traveler's diarrhea. It can be quite deadly and is often deadly outside of the United States. In the United States, it's not that deadly. What is the greatest risk behind any diarrhea, whether it was bacterial, whether it was viral, whether it was bloody or not? The number one risk with diarrhea is dehydration. 100%, the main thing you need to do with your treatment of any form of diarrhea is hydration. That may necessitate oral, IV, or some other techniques of getting the individual hydrated. I know with little kids, a lot of times you'll do this spoon technique where you're basically doing one spoonful every minute, every 5 minutes, making sure that there's some space in between and that they're able to tolerate that. Generally, observation is the treatment. The treatment is observation in rotavirus, norovirus, adenovirus, salmonella, and E. coli. If things are not improving, again, you'll have that stool culture and you may go through treatment. Treatment is very difficult with antibiotics because so much of the bowel is bacteria, and by treating one bacteria, you may actually open yourself up to a different type of bacterial infection, namely Clostridium difficile. 90% of acute infectious bacteria will last less than 14 days. The mean duration, 2 days. Mean, 6 stools per day. So those are some things that you want to think of. Rotavirus is a common form of infectious diarrhea that is found in kids. Norovirus is more common in old people. If an individual had rice water stools, you should be thinking of what type of infectious diarrhea. Rice water stools is a buzzword for Vibrio cholera. If an individual was camping and had drank some water, that was just like from a river, you may be thinking that they contracted Giardia. Giardia has very foul-smelling burps and very foul-smelling gas. Most of the time, the treatment is supportive. I know Giardia has a specific treatment for that because Giardia is Giardia is generally treated with metronidazole, and Giardia is a single-celled organism, and again treated with metronidazole. I believe metronidazole is actually something that they'll use to treat Clostridium difficile. Non-infectious diarrhea. Non-infectious diarrhea, in this case, what they'd be looking at, so what would be causing diarrhea in an individual that does not have either a virus or a bacteria? So take a second and think of what could be causing that. Causes include irritable bowel syndrome and inflammatory bowel syndrome. Irritable bowel syndrome is, again, a more psychosomatic manifestation. It is generally something that you diagnose after you have run all these different tests. You may have even done something like a CT scan, you're ruling out celiac disease, and you've just run test after test after test, and all the tests have come back normal, and then you say, this is probably due to the level amount of stress that you have and is more correlated with your anxiety and depression. And so you will end up treating it with some sort of antidepressant, anti-anxiety medication, SRI medication, and you may be also treating it symptomatically. If it's constipation, then you can be using fiber or Metamucil or milk of magnesia, or if it is more diarrhea, then you're going to be treating it with Imodium. Celiac disease is another form of non-infectious diarrhea. Celiac disease, again, is chronic. It's not something that is intermittent. It is a problem in the body's ability to digest celiac. So every time someone takes in gluten, they're going to feel sick, and they probably will have diarrhea every time. It should be consistent and chronic. How do you diagnose celiac disease? The great secret is it's diagnosed with a biopsy. However, the tests that we often run are a tissue transglutaminase or immunoglobulin A. Other forms of non-infectious diarrhea include Crohn's disease and ulcerative colitis. These are your inflammatory bowel diseases. Other things that could also cause a non-infectious diarrhea could be other dietary intolerances. So if you remember, celiac disease is intolerance to gluten, but so could an intolerance to lactose cause this, or a different form. So the door is wide open to hundreds of different dietary intolerances. Cancer could cause a non-infectious diarrhea. What would be the telltale sign of cancer is there should be blood in the stool that you could pick up through a fecal occult blood test. And if you're constantly getting blood tested positive in the stool, this individual is going to need a colonoscopy. What is the general workup when you're looking at non-infectious diarrhea? CBC, CMP, TSH, ESR, stool cultures, Clostridium difficile toxin. You may do ova and parasites to make sure there's not a Giardia infection. X-ray of the stomach, fecal occult blood test, stool examination for white blood cells. So that's a pretty hefty workup. The main thing is if you're looking at something like gastroenteritis, and if it's not gastroenteritis and it's not getting better and the patient continues to be ill, you're going to be doing a massive workup to get to the bottom of what could be causing this. We did not mention, but we'll get back to it later, what are some of the main differences between Crohn's disease and ulcerative colitis. Crohn's disease is usually bloody and it's chronic. The Crohn's disease can affect any part in the GI tract, including the esophagus, whereas ulcerative colitis is specific to the colon. Chronic frequent stools, usually bloody. So blood in the stool can also be indicative, not just of cancer, but it can be indicative of Crohn's disease or ulcerative colitis. Irritable bowel syndrome, IBS. So we've touched on IBS. Prevalence of this. How common is IBS? 10 to 20%. That sounds a bit high. I don't have written if that is 10 to 20% of the population or 10 to 20% of cases of chronic abdominal pain, discomfort, or constipation or diarrhea. So I apologize that percentage is somewhat meaningless. GI pain and altered GI function that has an unknown etiology. Signs and symptoms: abdominal pain, abdominal distress, crampiness. Constipation or diarrhea, could be nausea, vomiting, or GERD symptoms. What is the workup? So we just kind of reviewed a workup. So let's look at that again. I want you to think of this slowly. If an individual has this chronic constipation, you want to make sure that you have run a CBC and a CMP. You'll probably want to assess whether they have some sort of inflammatory condition with an ESR. They may have hyperthyroidism that could be causing it, so TSH with reflex T4. If you were going to look at celiac disease, you would run a tissue transglutaminase. You'll probably want to get a stool examination, which includes stool culture, ova and parasites, Clostridium difficile toxin, Giardia. The individual could also, if you're looking at something like H. pylori, a hydrogen breath test, X-ray of the abdomen, and consider a CT depending on the presentation and other symptoms. Treatment, supportive, and the treatment of IBS is generally just symptomatic management. As we mentioned, if it is nausea, they may be taking an anti-nausea medication somewhat chronically. If it's constipation, put them on Metamucil, change their dietary habits. Again, if you're treating this at its root, which we assume may be some psychosomatic root, then you're going to make sure that they're on some sort of antidepressant SRI medication. Now, inflammatory bowel disease is two separate conditions: Crohn's disease and ulcerative colitis. So we'll be looking at how to differentiate between the two of these. The main differentiation is the location. Ulcerative colitis is that form of the inflammatory bowel disease that only affects the large bowel or the colon. Thus, its name is ulcerative colitis, because it's the colon that has that inflammation. The symptom is rectal bleeding. So this rectal bleeding is usually associated with frequent diarrhea. In colon cancer, you wouldn't expect to see this severity of diarrhea. However, a colonoscopy is probably going to be done either way, because colonoscopy would be indicated if there was rectal bleeding, because a colonoscopy is going to be the diagnosis of ulcerative colitis as well as the diagnosis of colon cancer. So that's something to think of. If that rectal bleeding is ongoing, you're going to want to get a colonoscopy. Usually, ulcerative colitis should be having very frequent stools. In some cases, it could be almost up as high as 30 stools a day. And one of the things that I read, 30 stools a day is quite significant. And so that's usually not something that you're getting with just your standard illness. And especially if this is a chronic thing that's going on. Now, the inflammation can come and go quite to some degree, but there'll be some ebb and flow, but a lot of times people have some pretty consistent symptoms if they're not being treated. There are some interesting things that they like to throw out at you. Because it is an inflammatory disease, because ulcerative colitis is an inflammatory disease, it is sometimes related to a few conditions. Could you list some of those conditions that are associated with inflammatory disease? Uveitis, pleuritis, erythema nodosum, spondyloarthropathies. What are you going to do in the workup? The workup would include an ANCA, CBC, CMP, ESR, and cultures. Obviously, you want to make sure that there isn't a hidden infection behind this. You want to do a stool culture just to make sure. The ANCA, ANCA, is going to be helpful for the diagnosis and differentiating of Crohn's disease, which we'll be talking about next. And the absolute diagnosis will be through a colonoscopy and biopsy. How do you treat inflammatory bowel disease? Most often, the treatment is not covered by a general practitioner, but it will be covered through a gastroenterologist. The GI specialist will be giving them steroids. There is sulfasalazine, which is a 5-ASA medication, sometimes anti-tumor necrosis factors, and sometimes surgery. Basically, a colectomy is something that I believe that will be used to treat ulcerative colitis, since it is only affecting the colon depending on the severity. But again, usually that will be run through a GI specialist. Crohn's disease. Crohn's disease is diagnosed with an is diagnosed with PANCA blood test, ASCA, and I think you also run the ANCA in there as well. The definitive diagnosis will be a colonoscopy. So colonoscopy is the same thing that diagnoses colon cancer, ulcerative colitis, as well as Crohn's disease. However, they may not be having the lesions in the colon at the time. So if they're having colon symptoms, meaning the diarrhea and the bloody stools, then that may be an indication and that the timing is right to get a colonoscopy. There is another buzzword associated with Crohn's disease, and that is skip lesions. Skip lesions are things that are seen on an X-ray. Signs and symptoms include abdominal pain, cramping, gross bloody stools. It's more common in ulcerative colitis. Fistulas and abscesses. Fistulas and abscesses are associated with Crohn's disease. Diarrhea. That diarrhea can even occur at night, and you can have nighttime incontinence. That's sometimes how it will present in kids. Sometimes there's arthritis or uveitis. So speaking, again, more specifically of Crohn's, remember it can affect any segment of the GI tract. Skip lesions may be seen on an X-ray. It puts people at higher risk of colon cancer. The Crohn's is more often associated with uveitis, hypercoagulable states, arthritis, fistulas, fever. Signs and symptoms: abdominal pain, diarrhea, weight loss, more than 20 stools a day, bloody diarrhea, fatigue, anemia, malabsorption, perirectal abscess. Diagnosis, again, colonoscopy and biopsy. There is no cure specifically for Crohn's disease, and the treatment is very similar to ulcerative colitis. 5-ASA medicine. What is an example of a 5-ASA medicine? Sulfasalazine. Prednisone can be used to treat Crohn's disease. Methotrexate. Sometimes there are palliative surgeries and anti-tumor necrosis factors. Those would be medications such as riflumab and infliximab. So those are some examples of the treatment of inflammatory bowel disease. Moving forward, anal abscess and anal fistula. Anal abscess and anal fistula. An anal abscess and fistula can sometimes be an indication of Crohn's disease or an inflammatory bowel disease, but most of the time you may be seeing these in odd locations. There's some sort of unusual presentation. So if there's an unusual presentation of the anal abscess, anal fistula, or if they're getting recurrent ones, you might want to be considering Crohn's disease or ulcerative colitis. An anal abscess, infection arising from the cryptoglandular epithelium of the anal canal. 90% arise from obstruction of anal crypts. 10% due to Crohn's, trauma, or HIV. What is the most common cause, bacterial cause behind an anal abscess? Staph aureus, streptococci, E. coli, bacteroid fragilis, Prevotella, and Fusobacteria. Risk number 1. What is the number one risk factor for an anal abscess? The number one risk factor is having had a previous abscess. Signs and symptoms: pain. For anyone in a clinic who has seen an abscess, it's generally pain. There's a tremendous amount of pressure. So perianal pain, pain around the anus. Increased with sitting and defecation. These individuals, if they sit, it puts so much pressure in the anal area that they are just not wanting to sit. It would be extremely tender to palpation, and you may be able to palpate somewhere in the area and feel that abscess feeling where you kind of get some induration of the skin around that area. But if you're having this severe perianal pain just pushing around in that area, you want to be very suspicious of an anal abscess, and these are actually very complicated. Most of the time, they will actually be referred to a surgeon, a surgical referral in the emergency department. They may not, if the surgeon that may be doing it may be a GI specialist. The workup, you may want to do an ultrasound to assess the depth. See the difference between the abscess that you just get that's just sitting there near your abdomen and something that's going in the anal area or in the perianal area is that there's much more space for this to form fistula. In fact, fistula formation occurs about 30 to 60% of the time. So you may want to consider an ultrasound. You might want to refer the individual. If you're suspicious of this, you may tell them to go to the emergency room, and in the emergency room they may get the workup that they need, including that ultrasound, and then a referral to take care of this. The ultimate treatment is going to be the same treatment that you run into with any type of abscess, which is an incision and drainage and package to make sure that it doesn't just reform after that. Next, we have an anal fissure. An anal fissure is diagnosed by physical examination. You should be able to see a fissure, a crack, a tear or crack in the distal anal canal. Risk factors are trauma and constipation. They are generally very, very painful, and they'll be more painful with a bowel movement. If there is no pain, and an individual can feel something down there, painless blood is going to make you think of a hemorrhoid. If there is some bright red blood and there is a lot of pain, you're going to be thinking more like an anal fissure is there. Pain is usually severe. It's generally not pain at rest. Again, the diagnosis is made on physical exam. It's usually in the midline. If it is not, you might want to be thinking that this is coming from a different source. How can you treat this? Sitz baths and hydration, treating the underlying constipation, can be very helpful. Sitz baths can be very relieving. First line would be, again, stool bulking laxative, something like Metamucil. Second line, they will actually use nitroglycerin, 0.4% topically applied. Third line, Botox. If medical treatments are unsuccessful, then surgery is used to treat an anal fissure. Other things that you can use for the treatment would be more supportive treatments to treat it symptomatically. Hydrocortisone, lidocaine, and again, that topical nitroglycerin can be helpful as well. So that is anal fissure. Hemorrhoids, the patient generally will be presenting with what complaint? That they may have felt something, so there could be some sort of mass sensation in the anus, or they may be complaining that there is some blood and that they're recognizing when they're wiping their butt. Swollen blood vessels in the lower rectum. They can be internal or they can be external. If they are external, then they may have this perceived feel of a mass. One of the main risk factors of hemorrhoids is going to be pregnancy. This is very common. Those babies are big and they cause a lot of changes for women, and all that pressure can cause the blood vessels in the lower rectum to swell, and they may get a hemorrhoid. Some of the signs and symptoms, again, are rectal bleeding. It is painless, though. It is painless. And bright red blood on tissue, on toilet paper, usually painless. And its diagnosis will be usually something that you can see on physical examination. Other risk factors, we mentioned and got stuck on pregnancy, but other risk factors would be something like obesity, anal intercourse, or chronic diarrhea, or even chronic constipation should be put on there as well. There is a thing that can cause a hemorrhoid, and it's worth differentiating because, again, hemorrhoids are painless, but if there is pain and significant pain and you're not seeing an anal fissure, there may be a thrombosed hemorrhoid. I think I've seen about 3 or 4 of these in my clinical practice, and it's this big blue swollen looking hemorrhoid that is very, very painful. The treatment is what it was back in the day. It's been a while since I've been doing family medicine, but one of the doctors, he would come in and he actually would just excise the thrombosis, and it's very painful after that. There is rubber band ligation that can be used to treat the hemorrhoid that is not thrombosed. Injections, sclerotherapy. Sometimes you can treat these with just changes in lifestyle, making sure that the individual does not have chronic constipation, making sure they have high levels of fiber. Sitz baths can make them more comfortable. Avoid spicy and fatty foods. Steroid creams. Steroid creams can treat it because a lot of times one of the signs and symptoms that wasn't mentioned would be kind of an itchy butt. Sometimes people will elect to get a surgical maneuver and a hemorrhoidectomy. I also remember seeing that done in this surgery rotation, and those can be quite messy, depending on the extent of the hemorrhoids. So that is hemorrhoids for you. Since we've touched on this quite a bit, we're going to go into this in a more complete sense. If an individual is having blood in their stool, then you want to be considering colon cancer. Blood in the stool was also an indication of what did we run into? Some of the infectious diarrheas, but also things such as ulcerative colitis and Crohn's disease. Ulcerative colitis and Crohn's disease are diagnosed with a colonoscopy, and so is colon cancer. And colon cancer tends to be different from those in that Crohn's disease and ulcerative colitis have some very significant diarrhea, 20, 30 stools a day, multiple stools a day, whereas usually colon cancer tends to be much more insidious. So you're not going to get these very obvious signs. But if you did get an obvious sign of bleeding, especially chronic bleeding, then you're going to want to be thinking of colon cancer. What are the risk factors for colon cancer? One of the primary risk factors is going to be a sedentary lifestyle. People who are out there moving, who are out there running, tend to be at a significantly lower risk of colon cancer. Smoking will increase one's risk. There is obviously always genetic components when it comes to cancer. Animal fats, people who have a diet that is high in animal fats are at a higher risk of colon cancer. Red meat and alcohol. What type of cancer, what is the most common type of cancer or growth that causes colon cancer? It is usually an adenocarcinoma. Signs and symptoms of colon cancer: an anemia, rectal bleeding, abdominal pain, palpable mass, chronic constipation, chronic diarrhea, chronic bloating, GI obstruction, fatigue, cachexia. So this can be a very difficult diagnosis to make because by the time that you start to have symptoms, especially like a GI obstruction, you probably have stage 4 cancer. Anemia, it's probably going to be mild, and by the time you're starting to show significant anemia, you may have a stage 2, stage 3, or stage 4 cancer. Abdominal pain, Again, by the time you started to have some of these significant symptoms, the colon cancer may have grown to a point where it's a very serious condition. Diagnosis of colon cancer, again, is made with a colonoscopy with biopsy. X-ray can help, CT can help. The treatment is surgical. Colectomies are oftentimes done. They may need some standard chemo and radiation because that has to do with how cancer is generally. When an individual cancer is found, what they're going to be looking at is lymph nodes, and they will be looking at other areas. They may do an X-ray or CT of this chest to see if there has been any metastasis, to see if this has metastatized to the lungs or to the liver or to other organs. There was something that I remember they taught us that was it called a Sister Mary Joseph nodule. It would be a palpable nodule bulging in the umbilicus. Could be an indication of colon cancer, very late stage. One of the things you also want to remember is the screening. The screening is a colonoscopy at 50 years and then every 10 years. Annual fecal occult blood or fecal DNA every 3 years. And this will change depending on the risk factors. If someone has a significant risk factor, they may get this done earlier. I think I recall one patient in particular, and I don't know if this is the standard, this is just what was done for this patient, that he said that his dad was diagnosed with cancer at age 40, so they started doing screening at about age 30, like 10 years before the age that his dad was first diagnosed with cancer. So that would be some of the information on colon cancer. This was also included, and it is fecal incontinence. Fecal incontinence. What is fecal incontinence? Fecal incontinence is an involuntary loss of solid or liquid feces. Delete that last definition. Fecal incontinence is the loss of it's the inability to control bowel movements. So it's generally caused by old age, injury. It can be an obstetric injury in women or a spinal cord injury. Diabetes mellitus can be another cause of this because of the gastroparesis and just the problems that occur with nerves, that this can make it difficult to control your bowel movements. Again, the age and diabetes mellitus are two of the greater risk factors. If an individual was under the age of 40 and they were experiencing fecal incontinence, then the individual probably needs to go to a GI specialist where they can get a sigmoidoscopy or a colonoscopy. Anorectal manometry is used to assess the anal sphincter tone and to see if there is weakness in the anal sphincter muscle. Anorectal manometry and endorectal ultrasound and MRI can also be useful in the diagnosis. The treatment tends to be more supportive. We treat fecal incontinence by having people wear adult diapers. Zinc oxide can be helpful. Again, if you're thinking about diapers, they can get diaper rash and they're just having leakage from the anus that they're not able to control. Antidiarrheal medications would be things such as Imodium. What they wrote is the second line would be referral. Sometimes biofeedback can be helpful, nerve stimulation, and then third line would be colostomy. So that is fecal incontinence, and that will be part 1 of the gastrointestinal system.